Okay, can everybody see this? I believe so, right? Yeah, so far so good. Okay, thank you very much again. So me and Dr. Marshalek, psychiatrists in training, and we have been working for the West Virginia. We train here at WVU, and we have been working for the state for a while. And of course, the state and like Kentucky, we all have the same problem here. So we are hardest hit states. No, there's no question for that. And Dr. Marshalek actually is a founding person for this clinic. He started this clinic because we noticed some kind of clinical problems. We can talk more about it. But anyways, today, I guess the next 45 minutes, we're going to share with you this study and the outcome of this study, and also why we started this study, and what our findings are. So the name of this the article is Sublingual Buprenorphine Naloxone combination. Actually, we use Suboxone only in our clinic for many years. The multimodal management for high-risk chronic pain patients. So this is a chronic pain population and the high-risk chronic pain population. So we can talk more about the selection criteria and why we did this study. So first, disclosure, I have nothing to disclose, but I have to say in this study, we used Suboxone for patients who may not really fully met the criteria for opioid use disorder diagnosis. So in other words, we may have used Suboxone as an off-label use. So, and the learning objectives for this presentation is first we would like, I'm pretty sure this group, everybody's familiar with Suboxone, how to use it, and for pain control for opioid use disorder. But here's we want to emphasize the importance of comprehensive approach. That's the main thing. So the whole study is about so what kind of approach we used for this kind of high risk chronic pain patient population. And then we also, in this study, we're going to describe the clinical outcome of using comprehensive opioid addiction treatment model. So this is called West Virginia model, initiated from this department. Back in 2000, Suboxone was buprenorphine was approved for opioid use disorder treatment back in 2002. So we started using this medicine in 2004. Then this model was named code somewhere like in 2004, 2005. So also we want our audiences to understand the rationale of combined medical and psychosocial treatment for people suffering from substance use disorder and chronic pain. So that's learning objectives. So the background, well, I guess every study came with a reason. So why do we want to do this study? Well, we have clinical problems, right? We have issues we want to address. So for people with chronic pain and for people using prescribed with opioids for pain control, and there are many studies have been done, and I'm pretty sure this group is very familiar with that. Back in 2008, actually in Wisconsin, they did a very good study on about 900, I think it's 910 patients prescribed with opioid pain medicine for chronic pain control. I think the medium duration of treatment was about 16, 15 years. They found 80% of people actually they had unusual medication use. So of course there are many they developed I think a 15 item a questionnaire to evaluate the unusual using pattern. But anyways, so we all know in patients who are taking opioid pain medicine and their aberrant medication taking behavior. So of course that includes, we're talking about not overusing, misusing, diverting, and sometimes overdosing, right? We're talking about or using something else concurrently with other, we're talking about substances, different kinds of issues, different kinds of things. So that has become a public health concern. Also, another recent study, actually fairly recent, a systematic review of 38 studies showed an opioid misuse rate of 21 to 29%. That's about 1 out of 4. And addiction rate is about 10%, 8 to 12% in patients with chronic pain. So we're talking about this is a high percentage. So a lot of people misuse the opioid pain medicine, and a lot of people even like they meet the diagnostic criteria for a substance use disorder. So that is definitely a concern. So we have a clinical question: is basically patients are not using medications appropriately, and we need to find out how to help this patient, how to prescribe appropriately, and how to monitor. So that is our clinical issue we need to deal with. On the other hand, buprenorphine as a partial agonist of mu receptor, it also is antagonist for kappa receptor, and a very weak agonist for delta receptor, actually. So it is a pain. It was developed as a pain medicine back in 1960s in UK, and was used in Europe for many years as a pain management medicine. That medicine was proved to be safe, and also got FDA approval for opioid use disorder. So the question is, why not buprenorphine, right? And why not using buprenorphine for acute and chronic pain? So, well, the good thing is like last year, December 2022, and you don't really need a waiver to prescribe buprenorphine anymore, Suboxone anymore. Suboxone, I'm talking about Suboxone, right? For or buprenorphine, Naloxone, or buprenorphine sublingual for OUD. So that's just a note for everybody. And basically, you don't need a DEA, you don't need a waiver, and you don't need another DEA number to prescribe this medicine. But anyways, let me just summarize the slide. I borrowed this slide from ASAM conference lecture. So historically, 1966, okay, buprenorphine was discovered in a London-based, actually it's a food and nutrition business lab. And 12 years later, it was approved and used in UK as an IV opioid analgesic medicine. 1981, buprenorphine, Buprenex, was classified as a Schedule II medicine, and was approved by FDA as an injectable medicine for pain control. So it was approved as a pain medicine, but it's a different kind of formulation. And of course, the dosing was pretty low as well overall. But not until 2002, this partial agonist was not approved as a treatment option for opioid use disorder. But anyways, in 2002, luckily, now we got a Suboxone and Subutex, basically a sublingual form of buprenorphine or buprenorphine naloxone combination, approved by FDA as an OUD treatment option, and it was classified as a Schedule III medication. So that's great, right? And then 2010, of course, 2015, that we had different kind of other formulations that were approved for pain management. So that means buprenorphine works for pain, at least, right? And just a different kind of formulations. Okay, so back to this study. So the setting is since we had this clinical problem, we found this. We got a call, and Dr. Marshalek started this clinic, working with nurse practitioners first, two wonderful nurse practitioners first, and did consults. Actually, they were called to Ruby Hospital, had to see a lot of patients with pain. In the meantime, substance use problem, and so they started buprenorphine. But again, at the same time, we, WVU, the behavioral medicine and psychiatry, we had this MAT clinic, office-based buprenorphine for opioid use disorder population. So we have been very successful. We have treated many patients, actually 4,000 patients in 10 years time. Still have like a 550 active patients now. So we had a successful model. So we're trying to combine these models, and we basically started the clinic called High Risk Pain Management Clinic. And this clinic is physically located in Pain Management Center. So this clinic consists of a multidisciplinary team. So we're talking about, it was directed by an addiction psychiatrist. Also, the clinic has a pain psychologist, addiction therapist, case manager, and the nursing staff, all different kind of people, right? So it's a team. it's a multidisciplinary team. Same approach we use for people, with addiction problem here in this building. And the team, another thing is like the team also work closely with the pain specialists in the building, because those patients, remember, they had chronic pain, so they mainly basically they're regular outpatients of chronic the pain management center. So the team also closely work with pain specialists and other specialists to provide a comprehensive pain treatment. So that is our study setting. Admission criteria, basically, we included all those patients in our study, but the admission criteria for this clinic, anybody 18 or older, anybody with a chronic pain diagnosis, plus substance use disorder, or evaluate as a high-risk opioid user. So that is kind of basically they developed they used this instrument called a SOAP-R, a revised version. Basically, it's a screener and opioid assessment for patients with pain. I guess you guys probably know more about this question than me. But anyways, we had a psychologist, we had a therapist that did it. Usually, this evaluation was done by one of our psychologists, one of them. So we deem those patients, with high risk, and also they have chronic pain diagnosis. Then we basically we start seeing them in this clinic. So the treatment approach, like I said, is mainly a multimodal approach. But the main thing here is for pain control, we mainly use Suboxone, actually buprenorphine product. I don't think anybody in this study was on Subutex only. As everybody one person was on Butren first, but then transitioned to Suboxone. So everybody was on buprenorphine plus naloxone combination, sublingual form, for pain control. In the meantime, they still see pain specialists for any other additional treatment, pain management treatment, including talking about injections, different kind of things, procedures. Also, we provide a physical therapy on site as well. And the main things, because of the population, we have addiction psychiatrists running the clinic. Then we also provide psychiatric treatment. We treat the psychiatric comorbidities. And another focus is group therapy. So those patients are required to sit in the group to receive addiction counseling, addiction therapy. Of course, like any other pain treatment or substance use treatment, we have a contract. So we have a lot of rules. We have all patients must agree to regular pill counting and a random urine drug screen. Now, how important that is, but everybody knows that, right? Because, well, I want to use this slide to briefly talk about our co-clinic. So our comprehensive opioid addiction treatment model actually was developed by Dr. Sullivan many years ago. This is a group-based, phased, structured treatment program. So in the beginning, we see patients once a week. So it's called a beginning group. Patients before COVID, it was of course it was in-person visits. So patients come together in group setting, see the addiction provider for professional, a doctor for about half an hour. We call it medication management group. Then after that, we have 1 hour therapy group. Those are all required. So then after that, then of course they don't need to be in hospital, but we also, before COVID, we require them to go to peer support meetings to get some peer support. Does not need to be 12-step meetings, but we want them to have like a real peer support meetings. So we require them to do that, actually, 4 meetings per week. And also per insurance, they also required to do at least a once a month individual therapy session. So after 90 days, 90 consecutive days, this is a total abstinence program. So they're not, we have a list of things they cannot use, including alcohol, marijuana, and any controlled substances. Anything could be potentially addictive except tobacco. So they're not, basically per our contract, they cannot use that. So total abstinence program, patient agreed. Then after 90 days, 90 consecutive days, so patients will be eligible for the next phase of treatment, which is intermediate group. So at this time, we see patients once every 2 weeks. So the structure is pretty much same. Then after 1 year consecutive sober time, they can be advanced to advanced group. So at that time, we see patients once a month, once every 4 weeks. Basically, the structure is still same. They still need to do monthly therapy group for 1 hour after each medication management group. Then after 3 years, at that time, we assume actually most of the patients definitely they do, if we can retain them, they do very well. Actually, they have jobs, meaningful relationships. They're back to their normal lives. So at that time, we only see them once every 8 weeks. So that's a bi-monthly group, advanced group, no therapy. So at that time, we just still recommend them. We highly recommend them to continue the meetings, but we don't require them to do anything. So they only need to show up in the group setting to see us for medication group, not even required to do any therapy groups anymore. So this is the structure of the program. So as I told you, we still have 550 patients in the clinic. We have about 120 patients in advanced no therapy group. So we have a lot of patients. Our longest sobriety is about 19 years. So we have published articles on the outcomes of this model. So we know it was working. We know a lot of patients can get better. So we use that model for our high-risk pain clinic. So the only difference is the high-risk pain clinic, because for the chronic pain, they need to be on Suboxone. But in the meantime, we realized, because if they're still struggling with active use, and it's very hard for because of the structure, because of the setting in pain management setting, pain management center, that kind of setting. It's very hard for us to monitor them that closely. So we only take 2 patients, actually, those patients who have not used in the past 90 days. So in other words, so they have to be in the biweekly group when they enter the program. So enter pain management, a high-risk group. So at the time, for at least during the study time, we're talking about all those patients were already, if they had substance use disorder, they're already at least made to the intermediate group in the co-clinic already. So it's a kind of selected population. The highest level of care is bi-weekly, and it's still phase-based with the frequency, depending on treatment adherence. And this is pretty much same, we're talking about the, same structure. We copy the same structure from co-clinic. This clinic has low tolerance for active drug use. So at any treatment time, if a patient is actively using, struggling, a lot of times if we feel like this level of care is not enough, so we just transfer them to high level. So in other words, luckily, because we developed this clinic from our code model, and we have code clinic ready for them. So we have a higher level of care ready for them if they need it. So for this study, the subject selection, we basically included all patients enrolled in this high-risk pain clinic from March 2014 to February 2020. That's about 6 years. And those who did not remain in the clinic long enough for implementation of standardized pain assessment were excluded because we did not even have enough data. Because we're trying to figure out whether their pain, was controlled well. So we need data in order for us to do the analysis for the retrospective analysis. So those patients, we just excluded them. Mm-hmm. The pain assessment, of course, you guys know very well about pain assessment. But in this clinic, we use the VA hospital tool, this DVPRS, because it's a self-report, right? It's easy and it's easy to use, and 0 to 10 scale, like a pain evaluation, and also it combines with like facial expression as well, and it also includes functionality, kind of function and a performance evaluation as well. So that's good. We have data, right, for pain management, for pain control evaluation. Then we collected data. We kind of different kind of data we collected. We collected demographic information. We collected a psychiatric diagnosis. We collected what kind of medications they were taking. We collected their pain scores. We collected the buprenorphine and naloxone, basic Suboxone dosing, and the main other important things include duration in treatment, timing, clinic, reason for dismissal. If they were dismissed, then what the reason for dismissal? We went back to medical records. We retrieved the data, and what kind of psychotropic medications and they were taking before, during the clinic time, and even before they enter clinic, and also what kind of pain medications before and after starting the treatment. So this is the first table. So demographic information. First, we have like the mean age of this group. We have about 78 patients total, about 80 patients total. The mean age is about 53.9, and 62.8% of patients were males. Majority were white. That's kind of pretty consistent with ethnicity distribution in this state. And so it's about 50% of patients were not employed, did not have jobs at the time. Okay, those information may not be very accurate, because what we did is like sometimes the employment status was never updated during the treatment, throughout the treatment. So, but whatever we could get at the time. So that means the employment status could be before they entered the clinic, or could be after, or could be just during the clinic time, because whatever data we could get. Half of the population were married, and disability, interestingly, so 46.1% of patients had disability. So I believe that's pretty much consistent with other demographic, demographic information from other studies in pain clinics, pain like management center. Reason for admission. So this list was what we could get from the EPIC record. So we had like a high risk prescription opioid. This is mainly for referral, for the the reason from referral reason. So high risk of prescription opioid use or substance use, generally substance use. Now we don't even know what kind of substance patient, what kind of drug choice, and this overall substance use disorder. There should be some overlapping here, but then we just don't know. That's all we could get. Now opioid use disorder clear diagnosis actually were 11 patients. Some were using alcohol, cocaine, other things, but those percentages you add together, it won't be 100% because they overlap, right? Psychiatric diagnosis, same thing. About 50% of patients were diagnosed with major depressive disorder, and a lot of patients also had like anxiety disorder as well. I mean, PTSD. Some had like somatoform disorder and bipolar disorder. Okay, so chronic pain diagnosis. So majority of patients had chronic low back pain. That doesn't surprise you. And some had like chronic headache, migraine. Again, those diagnoses overlap. So some patients may have multiple diagnoses, right? So this is the medication use before, at baseline means before they start treatment, and during the in-clinic, it means like in clinic, how many patients were were prescribed this type of medication. And the newly prescribed means just those patients were started those medications during the treatment, mainly by our addiction psychiatrist. So you can see a lot of patients were on antidepressants. That's, it does not surprise you. We have a lot of patients on SNRIs, right? Because even like a lot of people, even 7 out of 11, you can see that 63% actually they were prescribed and newly started. Actually, our psychiatrist, addiction psychiatrist, initiated SNRI treatment during the clinic time, right? And some patients were on antipsychotics and the mood stabilizers. Actually, a lot of patients were actually started on those two medications. Basically, this is a table for non-opioid pain medication use, talking about NSAIDs, SNRI, and muscle relaxant and everything else. We put it as pain medication as well in the category. So this is the main result, actually. So we're trying to figure out whether buprenorphine product can help with the pain. So we try to correlate with their pain score. So first, this is only one of the ways to do it. But again, I still feel like we probably is not the best way. But given the retrospective study nature, that's for this clinic, because every patient had different kind of visit time, and so we realized, hey, how about just to plot something, their scores against in terms of their visit number. So with time going on, because we have a visit frequencies almost like everybody's every 2 weeks. With time going on, they could be seen by every 4 weeks. So how about just to find a relationship between the duration and the overall pain score and the buprenorphine dose. So this is what we found. With time going on, the longer they're into treatment in this clinic, the overall pain score gets better. So that's good, right? So overall, we pour them together. So patients, the longer the more visits they have with this pain clinic, the pain can improve. The pain score is just reflected by the pain evaluation, from this pain score. Then and the buprenorphine dose with time going on, and overall, the average dose increased. So that means probably a lot of patients may just, they require more pain medicine, or maybe just initiate with Suboxone and buprenorphine. And with time going on, then we made adjustment, and we kept increasing the dose because they need it. Maybe that's too. Buprenorphine dose is kind of related to the pain control. Actually, well, our findings kind of no, not really. So we did not find any correlation, a real like a basic positive negative, relationship between the pain score and the buprenorphine dose. So we have a lot of patients who actually had a good pain scores, even like they were on lower dose. So what really was working, maybe something else. So this is the interesting table, because we're trying to figure out who potentially, who can stay, who we can, and what kind of patients we can retain in this clinic. So who are more likely to stay in treatment, right? Because by the way, and the retention rate is always something we want to use when we evaluate the outcome of when we assess the outcome of any addiction treatment. So we're talking about a total. We try to find out, first whether just from the reason for admission, different kind of diagnosis or different kind of reasons. And so let's say for those patients with opioid use disorder, total 11. And actually, none of those patients got dismissed. So we almost kept all 11 patients with opioid use disorder diagnosis. That's kind of interesting. Well, it's not surprising because we use the code model here, right? And the high-risk prescription opioid use, we had actually 70% of patients, 71.8% of patients stayed in treatment, and about 28.2 dismissed. Those who were referred to us because of just general substance use, we had like 75% retained and 25% dismissed. And for those patients with major depressive disorder, total we had 40 patients, remember the first previous table? And actually 82% of patients we retained. And for those generalized anxiety disorder or PTSD, and still majority of patients stayed in treatment. And two borderline personality disorder patients stayed, and 80% of somatoform disorder patients stayed. So it's kind of interesting. The average pain score, those who stayed, of course, they had a lower score, which is kind of, understandable, because basically probably the pain got controlled well, and they might tend to, they tend to stay. That's possible. And the average buprenorphine dose, there was no difference. It's very hard for us just from this limited data numbers. It's very hard for us to conclude, talk about very meaningfully from a statistics perspective. So significance, we don't really know. So the discussion. So overall, there was a downward trend for overall pain score in relation to duration in the high-risk clinic. So with time going on, the longer they stay, the more visits they have with us. So the pain score tend to improve. So we knew that from from our analysis. And also the average buprenorphine dose showed an upward trend. So with time going on, we titrated up a buprenorphine dose. However, we did not really know whether buprenorphine dose was kind of contributing to the better pain improvement in the pain score, because we didn't, that relationship was not really there. From this study, we did have a relative high retention rate in this treatment. Comparing with our co-clinic, we only, I give you numbers in the next couple of slides. But this, overall, we retained, our percentage of retention is pretty good. A high percentage of underlying psychiatric illness. You have seen that from the slide 2 of the results. Basically, a lot of people had major depressive disorder. A lot of people had like anxiety disorder, PTSD, different kind of psychiatric comorbidities. A high percentage was prescribed SSI, SNI, sleep aids, and anxiolytics, or different kind of medications. Well, one thing I have to mention here is like we utilized the daily dosing here, but that was not really accurate, because from the MAPPIT system, the prescription was written that way, like daily 8 milligram or 4 milligram a day. But actually, we always encourage patients to split the dose because of the talking about pain management. The overall time is only for 6 hours we know that for buprenorphine product. So this is not really accurate. We put that in our discussion, but we really did not find any significant relationship between average overall pain score and the dose of buprenorphine, suggesting that some other component of this clinic may play a significant role in reducing pain scores. So overall, this is a multimodal approach. We're talking about integrated care probably is more important, right? So the relatively high retention rate demonstrated further support for a code-adapted integrated care model. So we don't really know whether it's a comprehensive approach or it's psychosocial factors. After all, our pain, a lot of things can make our pain better or worse, right? We're talking about, even like your rapport with your providers, and your attitude, and your stress level, your concurrent psychiatric conditions, all different kinds of things. So therapy has definitely played such an important role here. But we didn't know, we could not conclude that, right? Because this is a retrospective study. the problems with opioids in the treatment of most types of chronic pain. I mentioned this. This is so important here because you all as a group know this. So when patients were taking pain medications, regular pain medicine, 4 agonists, actually they had various side effects. They only basically, a lot of times they're never pain-free. They still have like, the pain may be better, but they still suffer, right? They still have like modest, probably mild or modest level of pain. And sometimes they become more and more sensitive to pain, and they're more painful as possible, hyperalgesia, right? That's also possible. And there also was a strong association between opioid use, regular opioid use, and the poor quality of life, as well as functional disturbance. But Suboxone doesn't do that. The buprenorphine, I always also say Suboxone, I'm sorry about that, but a buprenorphine product, it does not do that. Buprenorphine's FDA, now it has formulations that were FDA approved for pain control. It has similar analgesic effect as methadone. Many studies have supported that, and it's safe for long-term use. And Dr. Marshalek is going to talk more about it, basically why we should advocate for that. The many studies have been done in this. Basically, they found patients on buprenorphine-related product. They not only had pain control, but in the meantime, they have increased the functionality. So that is very important. Now, this is just we're talking about overall, and we dismissed the patients, and many patients were dismissed from the clinic because of other substance use. They used cocaine, they drank alcohol, they used methamphetamine, and so that means polysubstance use was probably a problem, and was a major problem, and is a problem we have to deal with when we talk about why those patients cannot be retained in our program, right? And we were surprised to find that 25.6% of patients with substance use problem and were dismissed from the clinic, but none of them carried the opioid use disorder diagnosis. So again, 100% of our 11 opioid use disorder patients stayed in the program. So the retention rate was higher than the regular co-clinical. Regular co-clinical is about less than 1 year, 12 months, we only retain about 40% of patients. Talking about it, this number is actually pretty consistent throughout the world, actually, a lot of places. So more than 10 years, our retention rate is about 15%. Well, there are a lot of things we can talk about, but anyways, the comprehensive approach probably is the most important thing, why we retain those patients with opioid use disorder. So that is the last slide of my discussion. Basically, what I'm trying to say is, as we learned from this study, is the presence of substance use, talking about chronic pain with substance use disorder, when you have comorbidity, is not really a roadblock in treatment. It's not really a barrier to any meaningful treatment. So we have ways to help our patients. The key is combination of buprenorphine, which is a safe product, with other psychosocial intervention, and a lot of important components of treatment, right? So this is, in one slide, the conclusion is substance use disorder, and especially OUD, complicate the already difficult management of patients with chronic pain. We know that. And the current study presents an example of integrated care that involves multidisciplinary teams and utilizes a stepwise group-based code model. And finally, buprenorphine is a promising substitute for traditional opioid in patients with concurrent chronic pain and SUD, high-risk opioid use behavior or whatever. So anybody you feel maybe not just a good candidate for regular pain management, probably, and with all this kind of high risk or comorbidities of psychiatric conditions, substance use disorders, and buprenorphine is a really good choice. Of course, the limitations pretty simple. This is a retrospective study. We cannot correlate anything. We cannot draw any conclusion. There's no causation, right? It's just association. And not enough data. It's a small group. We only have like 80 patients, 70, 80 patients total. And we did not evaluate the overall functionality. And for any good study on pain control and functionality and quality of life, they're very important variables. We did not have that, and a lot of confounding factors. It's very hard to say because basically we used, you know, it's a whole package. It's a whole package. You know, it's multiple components, and we cannot say buprenorphine it's just purely is a good medicine for pain control, and definitely you need everything together. Okay, so I'm going to finish here, and this acknowledgement. We appreciate help from CTSI and also all our staff members working for pain management team. So I'll pass the time to Dr. Marshalek. Thank you very much.
Thanks. I'll try to go quick because I saw some questions, and I'll go through this and hopefully answer some of them, but then rush through in case there's some others. I started as faculty at WVU in 2010, hit the ground running not long after that. So I was active in our MOUD program or MAT program that Dr. Zheng talked about, known as COAT. Not long after a couple years working there, started to collaborate with some of our colleagues and also spun off some dedicated programming for pregnant postpartum patients because there was a need there. So kind of that helped foster the creation of this, plus an ask from hospital leadership to be part of a pain resource management team. There was a question about that team. That team was based on a model that I think came out of Kansas that it was considered nurse driven. So APPs were kind of front facing as far as the team was concerned. They collaborated with an addiction psych and interventional pain doc. In our system, it got up and running with just me and 2 brand new FNPs. And there was a big need. It was happening when there were a lot of overdoses. It was happening when the hospital was growing, and we were seeing all different types of patients with active substance use. You know, somebody life-flighted with a fractured pelvis on 16 of Suboxone, trying to figure out how we manage their pain, whether we override with fentanyl or Dilaudid, or try to, you know, work with what the patient was already on. And folks that really just were getting you know, going from pill mill to pill mill somewhat unknowingly, and kind of getting worse and worse care as they were trying to kind of maintain on these opioid regimens. It was also at a time, if anyone was practicing at that time, a lot of folks were kind of just backing away from prescribing opioids. And if people were prescribing opioids, they were also kind of reinforcing things that were kind of in some ways making it harder to access care from them. And then also doing these assessments that sometimes bordered on forensic assessments of the patients before they would even set foot in the clinic and even be considered for an opioid. I grew to see that as foolish because I saw a lot of these patients on either side of these assessments, and they were just cross sections. So we kind of started to feel increasingly like it's good to assess for risk factors, but you shouldn't put all your eggs in that basket up front. You should do it in the context of continuity. Being a psychiatrist and an addiction provider as well, realized if you look at SOAP, CALMS, any of these kind of measures, ORTS, and so on, a lot of those things that would sometimes, in the wrong hands, unfortunately, be viewed as a risk factor and just kind of red flag the patient, and they wouldn't get any more care. I'd say, well, those are things I can treat. I can treat addiction, I can treat depression, and so on, modify some of those risk factors and maybe try to get them not as high as they were, and needed time and space to do that. I think as Dr. Zheng was going through this, though, one of the challenges we faced was we weren't sure, even after several visits in an acute hospital, whether somebody had a full-blown substance use disorder, maybe a remote history, maybe something in remission, maybe some depression, maybe some anxiety, maybe dismissals from pain clinics, but coordination of care, trying to track that down and really organize all that information, still couldn't. And we were left with patients that oftentimes still had very painful conditions, definitely had, you know, even if the question about OUD and at the time it wasn't DSM-5. Even if that question couldn't be answered, it was clear a lot of these folks we were seeing had physiologic dependence upon opioids. So that was the clock that was ticking the quickest in terms of like, okay, they're getting tuned up. What should they leave the hospital on? We couldn't leave them in the acute inpatient hospital and do this nice gradual taper off of opioids, right? They had to leave with something. That's where buprenorphine came into play. Because I think if you think about buprenorphine, and I think this is easier to sell to folks now than it was back then, it's like, it's inherently moderately long acting. It's hard to take too much of it. Yeah, it's unsafe if you combine it with sedatives or alcohol, but it's hard to take too much of it. It's moderately long acting. It might work in some cases where you're seeing opioid-induced hyperalgesia if you buy into that. If not, it's a different opioid, and we know about rotating them and so on. So we leveraged that, but then realized a lot of these folks wouldn't clearly fit into our outpatient addiction treatment program because there was still that question mark. So where do we put them? There weren't a lot of other providers that would accept them because we had the waiver constraints at that time as well. So that helped foster the creation of that programming that looked like our MOUD programming. One thing worth mentioning at the time, one of my colleagues from medical school who was also practicing at the time and working in palliative care joined forces with me at that time and was running a very similar programming, running similar programming for folks that remained on agonist opioids, but also had risk factors. So we had a couple different options at that time. When that fell by the wayside, we kind of only had that one. Trying to think. Can you advance the slide, please? That program started kind of at our psych center, but then as I began doing more work in pain, I was kind of brought into the broader based pain management center and was able to help move that clinic away from a psych facility because there was some stigma with that. A lot of patients we were seeing in the hospital were like, I don't want to go there with those people, and that was unfortunate. But it was nice to then be able to have programming at the building down the street, where then a referral to the interventional doc was easier to navigate, and some of the other modalities, whether it's chiropractic, acupuncture, massage, PT, or athletic training, was within arm's reach, not as easily accessible to mental health center. Yeah, if you could advance that just highlighted some of the challenges we faced. Yeah, if you could move that forward too. Yeah, move that forward too. So that also led, and the evidence has grown obviously since then, and I think it's shed more light on the ability to use bup. I'll shut up at this point because I saw some questions coming in. I don't know if someone wants to go through those questions, kind of make sure I don't miss any, or do you want me to go through them? If you guys want to just unmute and speak up.
There were just a few, and honestly, a lot of them were mine. If you don't mind going through that.
Yeah, not at all, not at all. All right, so I'm starting with the one about regulations. We didn't have as much pushback for off-label use. That wasn't scrutinized as much as I had worried about. I think in a lot of those cases, I would diagnose those patients with a physiologic opioid dependence, like an ICD diagnosis. I would talk to the patients, talk to their case managers about that. And that I wanted to kind of not formally diagnose them with an addiction problem, because then I would be kind of using that to treat addiction, in a non-addiction setting. Because if I really felt that they had a formal substance use disorder, specifically opioid use, they would move into the programming Dr. Zheng talked about. What was nice about having that high risk programming, are you all familiar with the pain refugee term? I see some heads nodding. It's just a lot during this period of time. A lot of, at least in our state, I'm sure in Kentucky, there were some pill mills popping up, and then how many of you would see patients that would be on pretty hefty regimens of opioids and oftentimes sedatives, and then that provider's gone? They're at the ED 3 in the morning. I didn't really see any patients that got better as that happened, those kind of transitions and kind of moving from provider to provider, that lack of continuity. So one of the things I kept in mind with this is like, yes, we'll bring them into this setting. I don't have a definite answer to whether or not they have a formal opioid use disorder and need to be in an office-based medication-assisted treatment program. But if I see them start to test positive for heroin or fentanyl or cocaine or meth in the context that can't modify those risk factors, at the very least could say, hey, you don't have to get kicked off this medicine. In fact, I think you should stay on it because it's also a good medicine for your opioid use disorder. You can come see me in a different building and stay on this, but we need to start focusing on your addiction. Because if any of you have had those conversations with folks, they don't always go that well. Those conversations went a lot better if it was like, hey, I'm not going to cut you off. You just need to show up somewhere different. You can stay on this medicine, and we're going to take a different approach to your care.
And we've got someone with their hand raised. If Dr. Kuchera wants to unmute, also had a question.
Yeah, oh my gosh, just absolutely amazing. I'm blown away. It's like a meaningful extension of Elliot Weiss et al. And POATS, P-O-A-T-S. Amazing. A couple things. In my experience, and also, I've been talking with AJ Manhapa and whatnot, we're finding about a 30 to sometimes 40% failure rate of buprenorphine, both for several reasons. First off, efficacy in inadequate pain management as buprenorphine alone. But secondly, also certain weird, quirky physiologic, some idiosyncratic intolerance, patients saying, oh my gosh, I get horrible headache, or, I have this incredible sedation or whatever that I don't have with other opioids. So for whatever reason, 30% failure rate, I don't know if that's consistent with your experience and what you guys might have done as a workaround that. Another thing is I've found that the addition of a mu opioid agonist, such as, for instance, oxycodone, can overcome a lot of the failure, the retention issues, by bolstering, or fortifying the analgesic effect of buprenorphine. And certainly, we've seen success in that realm with the co-administration of other opioid agonists, and that's something that's interesting. I'd like to throw that out there, but the huge problem that we're having is at the pharmacy and also with third-party payers, where they're rejecting the use of buprenorphine. I don't know if you guys are treating under F codes, like F11.20 is probably the most convenient, but whatever. But it's making me crazy, payer after payer is saying, oh, we're not covering buprenorphine for pain. I suppose you guys are coding for F codes. Even if I drop in an F code, they're still giving us a runaround. So we're having, and ASAM recognized this for buprenorphine access problems for the treatment of opioid disorder, that they're getting the runaround and what they call onerous PA issues. And I'm sorry, I got a couple other things. You guys have a wonderful program, but just like Dionfrio and some other programs, y'all are robustly supported in your particular micro environment. I think if you try to scale this to national communities and national settings, you're going to find a horrific lack of support where, so you guys obviously were not practicing low threshold, which is fine. So you were discharging patients who were positive for non-prescribed illicits. And I would like to, I'm wondering about what your positivity rate was. And I'm sorry, I didn't have a chance to look at your stuff for non-prescribed prescription opioids.
Yeah, this might be a good time to see. I know you said that's a limitation.
So
is anyone looking at that other data of the people who dropped out?
I think I guess the ones I would talk, I mentioned that earlier, like if somebody, most of the time it was a discussion about being able to stay on the buprenorphine. So if you're testing positive for opioids, which we saw, if I recall correctly, less often than some other substances. just because of, I think, the job that Bupe was able to do. I think our job with Bupe, as Dr. Zheng mentioned, was just to kind of fill in that gap and try to match that up with whatever regimens folks were using. So there was a question about 16. Yeah, we were capped at 16, mostly because of insurances and some of those regulatory things. But then also, I was seeing some of these patients were on less MMEs than, say, the patients using recreational opioids that I was taking care of in substance, use treatment programming. So that also led the dose to skew lower a little bit. But I think we were quick to then recognize that a lot of these folks had enough risk factors, kind of almost a Venn diagram style convergence of risk factors to make no one want to take care of them besides us. So then those discussions were easier. But that also meant that we would pounce on them once we kind of brought them into treatment and start treating them with things like SSRIs, SNRIs, oftentimes kind of misdiagnosed, depression and anxiety, often multiple different types of pain. We'd be able to get them in to start getting shots, or kind of have, once they were stabilized, and we could demonstrate to some of our colleagues in the surgical subspecialties that, they'll comply. We could get them to get that procedure that either, other people were putting off and so on. So I think some of that's buried within there as well.
So I don't want to take too much of your time, but very quick. So first thing is we have a very high opioid-free rate percentage. So we're talking about once in our regular co-clinic, we're talking about patients once they start Suboxone, or that's the only thing we use here. We don't use Subutex. So most people do not, they quickly stop using opioids. They might struggle with something else like methamphetamine and or different kind of other drugs, but the buprenorphine really works for people with opioid problem. We're talking for high percentage of patients. And for pain, I side notice, like I have a lot of patients. Personally, I have like about 120 patients in my co-clinic. A lot of patients, they have acute pain management. For acute pain management, in terms of acute pain management because of procedures, tooth extraction, even C-section, and talking about spine surgery. And the majority of people, I can tell you, like 90% of people, when did well with just a little bit PRN Suboxone, and they can went through the whole procedure. Talking about a post-procedure pain controlled pain management was not a problem at all. Well, we're changing now. Of course, we're changing our practice for marijuana use. To give you a quick answer, it's like we have developed even like a marijuana the THC code clinic. So before we learn that, we're kicking people out of clinic. Definitely, we don't do that. We just send them to high level of care. So we do not really dismiss patients. The dismissal is an old term we used, but now we don't dismiss them. We just send them to high level of care. For a second, it's like we do recognize some people just in terms of overall they're doing so better than marijuana is they're still using. So we try our best to help them, but again we developed a special a unique clinic for people. We are, of course, we don't encourage, we still provide continuous treatment to help them to have total abstinence, but our tolerance to marijuana use has also changed with time going on.
At that time, we weren't automatically intensifying people's treatment if they use cannabis. Like if they came into clinic and said, my pain was really bad, and I was having a bad day, I used to help my pain, that wouldn't mean that we just automatically referred them over. It may be something we're going to see a little more frequently, or we're going to add something to your kind of plan to help see if that goes away. And then if it kept kind of coming up and then looked more like a use disorder or other things were part of it, then that would happen. I think there was another question or comment about pain scores. I included the link to the DVPRS. We were collaborating with some folks from the DoD at that time, and that's where that came from. It's an interesting scale, I think, just based on some of the visuals. And as a psychiatrist, I was glad to see that they were asking about like stress levels and sleep, because when we'd have the patients fill those out as they came and went from their clinic visits, it would help guide me in terms of what I need to talk to them about, because I'd be like, how are you doing? And I'd be like, maybe focusing on their pain and their numbers and not even talking about stress, even though they wrote it down on that thing. So our whole team was really geared towards, I hope you guys know what I mean when I say this, ignoring some of the pain complaints and really, really reflecting it back to say, we care about your functioning. If your functioning is improving, then I think we can, so that was drilled in through some of the group-based therapy, some of the individual therapy we would do in the whole team, as well as our approach pharmacologically and non-pharmacologically to be very multimodal, multifaceted.
Well, it was a very, very robust discussion. It sounds like a very robust clinic, more data coming out from that, and how you guys have changed practice. We are over our time. It's now 5 o'clock, end of the day for some people, still in the middle of the day for others who have to get back to work. But would say, you know, with ASAM and AHPM and all this interest in this need that we know in the outpatient space, hopefully we'll be in touch, and there'll be another way of maybe of talking about these different models of care as we think about these things as so many more patients, people live in this space with really pain and co-occurring like dual diagnosis, psychiatric conditions, and then, you know, as you said, in the palliative care space as well. So thank you so much for your article, for your work, for ongoing work, and we hope to see you again in a forum